First of all, in my talk, I will emphasize the point that we are using the same molecule or target agent in a radioactive form. And that molecule is being used for imaging, and imaging determines the possibility for the patient to be treated with radiotherapy with the same target. So this is really an individual approach in patients with GAP-net tumors. But to introduce this concept, I would like to show you first of all the first molecular medicine in my view. And it is already about 67 years old, where people started to use radioiodine in the 40s. So there's already long-term experience with the use of targeted radionuclide therapy with radioiodine. And that is shown here that by the use of radioiodine, there is a lower recurrence of disease and mortality. So for papillary thyroid carcinoma, the principle of targeted radionuclide therapy works. And the principle for this use of radioiodine is very simple, that on the cancer cell, there is a specific transport mechanism that transports iodine into the cell together with sodium, by the way, so it is a symporter. And by binding to a protein in the cancer cell, it can stay there for a while. So radioiodine is transported into the cell, it sticks there, so you can do imaging if this iodine is radioactive. And if you use the proper radioiodine isotope, you can perform treatment. So imaging is based on radioiodine. You see here a remnant in the neck of a patient, huge uptake in the lungs. So this patient is a candidate to be treated with radioiodine. I would say that is normal knowledge known to everyone. So talking about GAP-net, the gastroenteropancreatic neuroendocrine tumors or carcinoid and islet cell tumors, and molecular medicine, in this case is based on the somatostatin receptor as a target, similar to the radioiodine transporter for thyroid cancer. And that is shown here that there is a G protein coupled receptor on cancer cells with high density, and such receptors are able to bind hormones, for instance, the somatostatin. So I would like to talk a little bit about the GAP-net in general, a short introduction. Then I will say something about the targeting of the somatostatin receptor, and I will show you examples of the anti-tumor effects of lutate, lutetium, octreotide. I will come back to this lutate. I will spend one slide about quality of life and survival, and will show you one case to show you how important this treatment can be. And what is important, that with this technique we are showing a proof of principle for the GAP-net tumors, but this principle can be extended to other tumors like breast and prostate cancer, also with the somatostatin analogs, but also with bombesin and NPY, other hormones. So I will talk here about the GAP-net tumors. First of all, the incidence of GAP-net is very low. It's shown here that the incidence is about 1 out of 100,000 population, and since the patients can survive several years, the prevalence is 10 times higher. There is, for cytoreductive therapy for inoperable neuroendocrine tumors, we can use somatostatin analogs, interferon alpha, radiofrequency ablation, chemoembolization, chemotherapy, and VEGF pathways interaction or pipeline products. But these lead to disappointing anti-tumor effects, or these are short-lasting. They have serious side effects and complications. And at the moment, the standard care of GAP-net tumor patients which are inoperable is chemotherapy only for islet cell tumors and supportive therapy only by octreotide if the patients do have symptoms like diarrhea and flushing. That is all what is standard care at the moment. So I would like now to show you the results we have by using peptide receptor or somatostatin receptor radionuclide therapy for the GAP-net tumors. And it is now well known that in about up to 90% of the tumors, the primary and the metastases, these tumors do express high densities of somatostatin receptors. Another issue is that these tumors are radio resistant, so it is not the best model to test this principle. One word about somatostatin analogs. After the discovery of somatostatin, the Sandoz company, or Novartis, started a huge project to get a stable analog of somatostatin, and they succeeded in the production synthesis of octreotide, only 8 amino acids. For nuclear medicine, this molecule was changed over the time by inclusion of a tyrosine, and here for the octreotide, a missing group of alcohol. These changes are very, very important by, for instance, leading to a much higher affinity to the receptor, or here by making this product selective for only one of the 5 subtypes of somatostatin receptors. These molecules have to be linked to radio metals. That is impossible directly. You need a bridge for this binding, and that can be done by the DOTA acetylate or DTPA. So in fact, if you are talking about the structure of a radiopeptide, you can recognize the peptide, the somatostatin analog, that binds to its target. There is a bridge, a linker, the DOTA or the DTPA, and that can bind the radionuclide. So this whole combination is the key for this lock. And in my talk, I'm talking about the radionuclide lutetium, the peptide octreotide, and we call it lutate. And this lutate can bind to the somatostatin receptor. So that is the principle, not so simple as radioiodine alone for the transporter. The way we scan patients or treat patients is simple. For imaging, it is a IV injection targeting to a tumor where the receptors on the surface will bind this radiolabeled peptide. And then this group is internalized and will stay there in the cell. For the treatment, this will be done by a IV infusion during 30 minutes. We started in '87 with this approach for imaging. That was very successful, but now we are about, 20 years further, and we have now sort of magic bullet. One example is the somatostatin analog DOTA-TOC labeled with gallium, and nowadays there are very sophisticated SPECT CT or PET-CT cameras, and you see here one case with a tumor here in the leg, one tumor here. The problem of PET is that it is very sensitive to find tumors, but it is not so good for the anatomical delineation. That is much better by CT, and you see the big tumor here very easily shown, but this tumor is missed here on the CT, but by merging the two images, you can now localize the tumor there, and that is important, for instance, for surgery. When such a scan or tumors are positive, by the way, these are normal kidneys, the spleen, and the liver, but when these scans are positive, those patients are in principle candidates for treatment with radiolabeled octreotides. And we started in '92 with the first patient treating with high doses of indium-labeled octreotide. And nowadays, the third generation is the lutate. You see here the practice. The patient is sitting here with 2 pumps. The patient is infused for 4 hours with amino acids to protect the kidneys. And since this amino acid infusion leads to vomiting, the patients are being treated with IV anti-vomiting drugs. And then the real treatment is a 30 minutes infusion of the lutate, and the patients are hospitalized for 1 night.